Hi everyone, this is Jackiey, Christina, Julia, and Alison, and we've designed a novel anti-necrotic and anti-inflammatory drug delivery platform for BPH. The first objective for our design is to remove the necrotic tissue, and our second is to lower the inflammation of the prostatic area with pharmaceuticals.
So our design, called HENRII, is going to utilize the normal TUNA procedure, and TUNA is a thermotherapy treatment that uses radio frequencies to ablate prostate tissue, and it's one of the most successful treatments for BPH, so we decided to use that. At the end of TUNA, it's going to remove the needles and insert the hydrogel needles. We have two hydrogels. One contains the anti-inflammatory drugs, and the second one absorbs the necrotic tissue.
So the first hydrogel that's going to be responsible for reducing inflammation post-operation in the prostate is going to release pharmaceuticals. So specifically, it's going to release inhibitors of the inflammatory cytokines, IL-1 beta, IL-8, and IL-18, or their receptors equally viable. And it's also going to release synthetic IL-4 and IL-10, both of which are anti-inflammatory. And we've selected some of these because it models the biochemistry more after apoptosis, which is controlled cell death and does not cause inflammation, rather than necrosis, which is what causes inflammation. So our material for the hydrogel is methylcellulose, a natural polymer. It's very biodegradable, very biocompatible, and most importantly, it thermogelates at 50 to 55 degrees Celsius, which is the temperature window of tuna. So it's injectable, which is convenient, and it will automatically gelate upon injection into the heated tuna site. So our second hydrogel is the one which is performing the function of debridement, or absorbing the necrotic tissue from the site. And we have a 30 milliliter loading capacity, which we've selected because that's the difference between the initial and final volumes of the large prostate and then finally the normal size prostate in the procedure. So we will inject this hydrogel in a pre-gelated form, and it should have 25 micrometer pore sizes, which we have chosen because that is subcellular, smaller than the 30 micrometer prostate cells. So that way it will absorb just necrotic contents, which are subcellular, rather than prostate cells. And this material is PLGA, PEG, and functionalized to adhesion peptide for biocompatibility. The overall goal of this hydrogel is not just to remove the necrotic contents, but rather to prevent the contact between necrotic tissue and the ECM or cellular receptors that will trigger inflammation and cause morbidity and BPH recovery. So to evacuate the contents from the necrotic hydrogel, we are also using this device which we have sketched, and it is a small minimally invasive siphon that will vacuum out the necrotic contents from the necrotic hydrogel. It should have a less than 2 millimeter diameter, and we feel that this is okay to use for our design because compared to the precedent of catheterization, which is often required in BPH patients who cannot urinate due to the severe inflammation post-operation due to necrosis, this would be less invasive and would increase the chances of preventing catheterization.
We used MATLAB to create a model to investigate what needle size we should use to inject the hydrogel into the patient using a volumetric flow rate equation. The needles modeled included 15 gauge through 24 gauge, which you can see in the legends on the bottom of our graph. We need to ensure that the clinician is not injecting the hydrogel too quickly, at a speed which could harm the patients. Now we'll zoom in so you can see the data more clearly on the 4 to 10 seconds time scale. By zooming into the graph, we can get a better idea of what needle will work best. As you can see, as the physician takes more time to inject the hydrogel, the flow velocity decreases. From this data, we have concluded that the best candidate for injecting our hydrogels would be an 18 gauge needle. In an article from the NIH, we found the average male urethra has a diameter of 8 to 9 millimeters. The tip of the 18 gauge needle has a 0.838 millimeter diameter, which means that it will cause slightly less distress to the patient than 15 to 17 gauge needles, all of which have a diameter greater than 1 millimeter. This may help patients avoid catheterization. At the same time, needles with smaller diameters will cause the hydrogel to be injected at higher speed when the same amount of pressure is applied to the syringe. This is because of the decreased area through which the gel can flow. To be safe, we eliminated the needles which have a flow velocity of greater than 100 milliliters per second at some point on this time scale. This has left us with 18 to 21 gauge needles. From there, we conclude that we should use 18 gauge needles since they cause less distress than larger needles and have an injection velocity of 50 milliliters per second during a 4-second injection time, which is roughly half of the maximum injection velocity we want to see in this time scale. This needle size has the additional benefit of being the same size as those used during the TUNA procedure itself.
The other model we want to look at that is relevant to our application is the hydrogel release kinetics. The release profile of the pharmaceuticals is important because releasing in a controlled fashion prevents toxicity, which needs to be done prior to translation to the clinic. So the first thing we want to do for our pharmaceutical cocktail is determine the minimum toxic concentration, or the concentration which will cause an immune response. And that is done using a cytokine assay in 1 milliliter of serum, which is similar to an ELISA and has various antigens on the plate. And so we'll monitor for an immune response. So once we've determined the MTC, we want to make sure that we never exceed that with our release profile. It should stay in the therapeutic range, which is defined as greater as the minimum effective concentration, or MEC, and less than the MTC, which you can see in the figure. Ideally, it will be a linear release profile, and ideally it will be a zero order or relatively constant release over time. So how do we achieve this release profile? Well, there are two main ways in which drug can be eluted from a hydrogel. The first is diffusion, which is faster. The second is degradation of the gel, which is slower. Depending on whether we want to go faster or slower, we can tune the pore sizes in the hydrogel to make the system rely more on diffusive transport or degradation of the gel. So if we make the pore sizes smaller, then we can achieve a system that relies entirely on degradation, which is a very slow release profile. And that type of system has a diffusional exponent of 1 in the Richter-Pepys equation. So that's a linear release profile, which would be the most controlled.
So using our system, we're sure that catheterization will no longer be required, and also pain will significantly reduce after TUNA treatment, and that the recovery period will be shortened from months to weeks.
In the future, we'd like to model the hydrogel kinetics and pharmacokinetic release profile for hydrogels, and ELISA assay will make sure that there's a minimum toxic concentration of the pharmaceuticals and ensure that there's proper immune response. Our in vivo testing will use BALBC murine models because they reflect human immunological responses. And lastly, we would like to incorporate a vacuum type device that we would be able to remove any leftover content from the degradable hydrogel and complete our treatment. In all, we think our design will return normal prostate and bladder functions to patients with better success than TUNA alone.
Thank you.
Thank you.